Today we're going to discuss the treatment of refractory periodontal disease, which today we would call aggressive periodontal disease. Now, what is the key to understanding the refractory or the aggressive case? Well, the treatment or the management of this of the refractory or aggressive case involves all different aspects of periodontal therapy, such as mechanical debridement, surgery, culture and sensitivity testing, antibiotic therapy, host response, systemic health, recall intervals, and compliance. And to this day, it still has not been fully elucidated whether the etiology is a combination of these microbial and host factors, or whether in fact there are specific etiologic factors involved. So this study was done, and the patient selection involved subjects being recruited from patients treated for moderate to advanced periodontitis in my private office. There were 146 patients, 77 female and 69 male patients. The clinical parameters alone were unreliable indicators of disease activity, and these are also poor prognosticators of the treatment response that we hand out to all these patients. On the other hand, antibiotics are useful in the treatment of some periodontal patients, but the advantages of culturing and using antibiotics in all patients is a controversial situation. The purpose of the study was to evaluate the efficacy of obtaining baseline culture and sensitivity data on a routine basis for these patients with adult periodontitis, and to establish guidelines for the use of this data in the diagnosis and treatment of adult periodontal disease. And the title of this study then was Routine Anaerobic Microbial Culture and Systemic or Systematic Antibiotic Usage in the Treatment of Adult Periodontitis, and this was a 6-year longitudinal study. These patients are still in the practice, and some of them now have been going for almost up to 25 years post-treatment. The patient selection, there was the exclusion criteria. Systemic antibiotics could not be given within 3 months. All cardiac, gastrointestinal, metabolic, hematologic, or other immunologic problems were excused. Pregnancy was excluded from this study. As far as exam and diagnosis, a comprehensive periodontal examination was done. Periapical radiographs, a baseline anaerobic culture was done, and then the diagnosis into chronic adult periodontitis, rapidly progressive or aggressive periodontal disease, refractory periodontitis. These were the different types of periodontal diseases which we diagnosed at the outset of therapy clinically. Initial therapy consisted of oral hygiene instruction, subgingival scaling and root planing, extraction of hopeless teeth, and a 2-week maintenance regime. A reevaluation was done every 6 to 8 weeks. Clinical examination was done at this time, as well as an anaerobic culture. This was handled by Dr. Ben Hammond at the University of Pennsylvania. And depending on the initial therapy, which was the scaling and root planing and oral hygiene, there was either a reduction of pockets with reduction of bleeding on probing, there was a reduction of bleeding on probing only, or there was a reduction of neither. And the third group also did not respond to scaling and root planing without antibiotics, and this was placed into the aggressive group. The placement into one of 3 categories meant that there was a successful treatment, which was the oral hygiene and scaling and root planing. The patient then went straight into the recall program, or if that was not, then it went into the second group, which was surgery, or the third group, which was the scaling and root planing with antibiotics. What happened was then that the patient went back to the recall program, and based upon clinical findings, the patient either went into the surgical group without antibiotics or back into the scaling and root planing with antibiotics. If this failed, then surgery with antibiotics. And then after all of these three various facets of treatment, the patient went back into a maintenance group. If there were any breakdowns in treatment, if in the clinical situation the patient was retreated, either with scaling and root planing, with or without antibiotics, depending upon the clinical findings, and went back into the maintenance group. Microbial sampling, these were pooled anaerobic cultures from the deepest probing in each quadrant. TO was the baseline exam, T1 was after scaling and root planing at reevaluation, T2 was after scaling and root planing with antibiotics, T3 was post-surgical evaluation, T4 was 12 months post-treatment, T5 was 36 post-treatment. Patients were monitored for AA, Eikenella rodents, Prevotella intermedius, Porphyromonas gingivalis, and Wallinella recta. And this is clinically one of the cases that we treated. You can see the severe disease in this patient with tremendous probing depth and recession. And our clinical results after these examinations, as we said, were the three different entities of chronic periodontitis, refractory periodontitis, or recurrent periodontitis. And what we found was that as far as the chronic adult periodontitis was concerned, there were 120 cases, of which 17 of these were then further diagnosed into a refractory case because they did not heal after the scaling and root planing or surgery. And on the slide you will then see the pre-treatment diagnosis on the left and the post-treatment diagnosis on the right, and the number of cases before initial therapy and after initial therapy. And this is the same case after occlusal therapy and pocket reduction surgery had been done. Now, if we looked at the chronic adult periodontitis cases, 35 of the 116, there was a positive response to IP or initial therapy, and therefore these went straight into the maintenance group and required no surgery. 81 of the 116, there was still a positive response, bleeding on probing with persistent pockets after scanning root planing, and these then went to the second group, which was pocket reduction surgery. And you can see the probing depth and bleeding on slide number 1 marked result number 1, which was the initial clinical parameters at TO at the beginning of treatment. And probing depth was ranged from 6.8 to 7 millimeters with various different standard deviations from 0.6 to 0.8. And bleeding upon probing ranged from 89 to 93.7% with standard deviation ranging from 6.3 to 7 millimeters, to 7, depending upon whether they were chronic adult periodontitis, the rapidly progressive or the aggressive cases, or the refractory periodontitis cases. On this slide, which is result number 2, you can see that more than 95% of patients with chronic adult periodontitis were successfully treated with mechanical therapy alone. And if you look at TO, you can see that the bleeding on probing and probing depth went all the way down to 3.1 millimeters and bleeding index of 6, which was a tremendous improvement from the 93%. The group 2, which was the surgery without antibiotics, there was again a dramatic improvement in result, whereas before there was bleeding on probing in 93% of cases and probing depth ranging 7 millimeters. These went down to 3.2 millimeters probing depth and a bleeding index of 6 at 36 months. So there was good result, and these were maintained over the 3 years. In the third group, which was the rapidly progressive group or aggressive group, without antibiotics, there was improvement, but not that great of an improvement, and only approximately 1/2 of these patients were treated successfully without antibiotics. So there is a group of patients who you may in fact diagnose with aggressive periodontitis that you can treat without antibiotic therapy. You're doing routine scanning and root planing, and surgery pocket elimination surgery, and these will respond. Now the fourth group was the aggressive group with surgery and antibiotic therapy, and there was in fact a very good result obtained with the antibiotic therapy, which with the surgery and antibiotics, and this showed that this group did not respond to the mechanical therapy alone, but also had to have the addition of antibiotic therapy, and these cases were maintained for 3 years with probing depths of 3.1 millimeters on an average and bleeding indices of 4.6, which is excellent. Group 5, which was the refractory group, in fact, were also well treated with systemic antibiotics, and these did not respond with localized scaling and root planing or mechanical therapy. The fifth group, which was the refractory group, there was absolutely no response to treatment with or without antibiotics, and there was a rebound after 3 years up to 6 millimeters in probing depth, and almost 50% of these patients showed bleeding upon probing. If you look at the first group then, on this slide which says group 1, you can see the improvement at times T0 to T5 with maintenance of the result, both probing depth and bleeding index. The second group, which was the chronic periodontitis with surgery without antibiotics, again there was maintenance of good result after 3 years. The third group, which was the positive response to initial therapy of the rapidly progressive patients, went to pocket reduction surgery, and the fourth group was the group without any response, scaling and root planing or pocket reduction surgery with antibiotics. So you can see then there was a very minimal group of patients that required antibiotics. However, none of the chronic adult periodontitis cases required antibiotics and responded extremely well to pocket reduction surgery and scaling and root planing, or scaling and root planing alone. Now 13 of the 17 cases which were initially diagnosed as aggressive cases, there was a positive response to initial therapy and pocket reduction surgery. So did that mean philosophically, in fact, that cases that were diagnosed as aggressive cases and had the microbial milieu of the cases that we thought were aggressive cases were in fact not aggressive cases, but chronic adult periodontitis cases, we are not sure of. But these responded with localized therapy and surgery. 4 of the 17 cases, there was minimal response to any therapy. It was unable to sustain the results with or without antibiotics, and all of those cases, strangely enough, were diagnosed with systemic disorders. So these were the 5 different groups which we treated, and those were the responses that were obtained. Now, when we look at the microbial milieu, you can also see that in group 1, at time 0 and at TO and T1, there was a dramatic improvement in P. gingivalis and P. intermedius, which were our marker microorganisms. And these were maintained all the way through the 3-year treatment following that we had. So in group 1, which was the chronic adult periodontitis with good results with initial therapy, all patients were positive at baseline, but they were markedly reduced at T1, and these were maintained for 3 years. If we look at group 2, you can see the same result where the microbial numbers were reduced from 68 all the way down to 9 and 20%, and these were maintained for 3 years. In group 2, the same thing was found. The number was reduced at T3, which was the third examination, which was at 6 months, but rebounded slightly later on. Group 3 and Group 4 were those groups which required antibiotics, and these results were maintained. And again, you will see from the cultures and sensitivity testing that the microorganisms were reduced from 71% all the way down to 29 and 17% of them were again maintained for 3 years. As far as the aggressive cases with antibiotics and surgery, again, positive results were taken at T3 and T5, but they were much, much lower than they were at T0, which showed that there was a maintenance of result. Group 5 was the situation where at T0, P. gingivalis and P. intermedius were 100%, and at T5, these were rebounded back to 70 and 80%. So there was no maintenance of result with initial therapy, and there was a rebound not only of the clinical findings, but also of the microbiologic findings. So when we see the results of this project, or this research project that was carried out, we see that these results confirm most of the previous investigations in this field. Mechanical treatment is effective for the adult periodontitis case, and all of the 116 patients with chronic adult periodontitis were successfully treated with scaling and root planing and surgery with or without antibiotics, or with or without surgery. That means that many of the chronic adult periodontitis cases were successfully treated with initial therapy alone or with surgery, and the probing depths and microbial samples were maintained after 3 years. The results also confirmed that 90% of the patients initially diagnosed with chronic adult periodontitis respond extremely well without antibiotics and do not require antibiotics, and only 4% of those initial cases that were diagnosed as chronic adult periodontitis were retrospectively diagnosed as aggressive cases. Groups 1 and 2 maintained good response over a 3-year period. Culture and sensitivity testing with antibiotics was found to be valuable in the treatment of the aggressive cases, and more than half of the aggressive patients did not respond well to initial therapy and required systemic antibiotics throughout treatment. Group 3 responded the same as Group 2, thus a segment of the aggressive cases exhibited a similar response to that of chronic advanced periodontitis. In other words, there are a certain minimal number of aggressive cases that in fact will respond without antibiotic therapy. Groups 4 and 5 demonstrated an excellent response after antibiotics were used, and these were maintained over 3 years, and all 4 patients in Group 6 continued to exhibit breakdown over 3 years. All of these cases were diagnosed with systemic conditions such as a poor host response to periodontal pathogens. So you can see then that this shows that the microbial pattern clearly indicates that mechanical debridement alone is the treatment of choice for chronic periodontitis, and that antibiotics is not needed to treat this portion of the population. An empirical use of antibiotics during initial therapy is not supported by these results. The small subset of the population with aggressive cases do benefit from the use of antibiotics, and diagnostic cultures are important in such cases. Routine culturing of adult periodontitis population, however, is not supported. Our conclusions based upon these findings then: the majority of patients prospectively diagnosed with chronic adult periodontitis do not require culture and sensitivity data. We recommend that they be treated with mechanical therapy only, and cultures should only be taken before therapy in patients known to have aggressive breakdown. The use of antibiotics is a beneficial adjunct to treatment of these cases. Patients with retrospectively diagnosed Refractory or aggressive cases constitute a very small percentage of the total population, and we recommend cultures be taken in these patients only after a lack of response to conventional therapy has been observed. No distinct microbiologic profile was found for the 3 diagnostic groups. Other individuals, in fact, have shown that there may be distinct microbiologic profiles, but in this subset, there were no distinct microbiologic profiles. Patients with rapidly progressive or aggressive disease tended to have more species of organisms at the initial culture than did patients with chronic adult periodontitis. However, this difference had no bearing on the patient's response to treatment. Therefore, our conclusion is that routine culturing and antibiotic therapy is contraindicated in patients with chronic adult periodontitis, but may be beneficial for successful treatment of patients with rapidly progressive disease. I thank you very much for your kind concern.